Ma'am, with your permission, shall we start?
Yeah, you can.
Thank you.
Just showing something, the meeting is being recorded. I'll just click on continue.
Yes, ma'am. Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box so that at the end of the webinar, we'll have a short Q&A session. So let me welcome today's our eminent speaker who constantly desire to learn, and also she updates each and everyone's knowledge through her webinars and awareness programs. So let me welcome Dr. M. Madhavi ma'am. So it's my privilege and honor to welcome you, ma'am. She is a senior consultant gynecologist and obstetrician and laparoscopic surgeon practicing in West Maradpalli, Secunderabad. She has about 22 years of practice and consulting experience. She did her medicine and DGO from Jawaharlal Nehru Government Medical College, Ravi Shankar Shukla University, Raipur. And she is also a consultant at Geeta Multi Specialty Hospital, West Maradpalli, Secunderabad. She is also consultant at Basant Sahane Hospital and also consultant at Yashoda Hospitals. Her field of interest are high-risk pregnancies, vaginal surgeries, infertility, and laparoscopic surgeries. She has done her fellowship in laparoscopy from World Laparoscopy Hospital, New Delhi, accredited to VATS. She has a strong desire to learn and consistently update her knowledge in all fields of obstetrics and gynecology. She has given many guest lectures on adolescent girls, obstetrics, emergencies, cervical cancer, cancer vaccines, and is on the experts panel for cervical cancer vaccine. She is regularly conduct camps for anemia, thyroid screening, BMI, osteoporosis, and screening for breast tumors. She has conducted many virtual CMEs during the pandemic on GDM, emergency contraception, nutrition in pregnancy, amongst others. She regularly attends CME programs, workshops, conferences in India and abroad to keep abreast of the latest development. She is also in the subcommittee for health for All India Industrial Exhibition and member of the governing body of L.N. Gupta Memorial Health Center, Hyderabad. She is a life member of FOXI, IMA, and IAGA. So, with this, we welcome you, ma'am, for today's webinar. And the program is streaming through the Shield Connect, which is a digital platform to connect all the doctors at one place. You can find the today's speakers' past webinars and upcoming webinars in the Shield Connect webpage. I request all the delegates to please go to the Shield Connect page where you can find all the awareness programs, webinars, blogs, and other uh, the special day awards. So today is coming to the today's topic. The gestational diabetes is common in pregnancy and is associated with adverse pregnancy and fetal outcomes. Currently, population-based data on the prevalence of gestational diabetes are limited in India. However, GDM testing and management is mandatory during pregnancy. So now, without wasting much time, so let me turn over the time to Dr. Madhavi Madam to talk on gestational diabetes. Over to you, ma'am.
Thank you so much for the kind words. I thank the organizers, Shield Connect, for giving me the opportunity to speak on a topic which is very close to my heart. And I love this right from my time when I was in the undergrad. So that was an area of very keen interest. And we would just, my field of interest is, will touch upon a short of pathophysiology and a lot on the medical therapy and the pharmacological therapy. All my colleagues and my dear friends, I welcome you to this academic session. Hope you all are doing well and be safe, stay fit, continue to work, taking all the COVID appropriate behaviors. So let's start with the session. Yeah, I welcome you to this session on gestational diabetes. Now, we just touch upon the classification and diagnosis of diabetes. Type 1 diabetes, where we are like, it's mainly due to the autoimmune beta cell destruction. That is, most of the time, the insulin deficiency is there, or hardly any insulin production, failure of insulin production. But in type 2, there is a progressive loss of beta cell insulin secretion. Now, the specific types of diabetes due to other causes, they are like monogenic diabetes, neonatal diabetes, drug induced, chemical induced, so many group they come into the specific types. Gestational diabetes, that is the talk of my day. It is diagnosed in the second and the third trimester that was not clearly overt diabetes prior to gestation. There is a word coined hyperglycemia in pregnancy that can be classified as diabetes in pregnancy. So it is detected prior to pregnancy, that is type 1 or type 2. Diabetes first detected in pregnancy, type 1, type 2, and then diabetes continues post delivery also. Now, gestational diabetes is pregnant women who have never had diabetes, who have their high blood glucose levels during the pregnancy. This is transient and disappears after delivery. Now, gestational diabetes is the most common cause of hyperglycemia in pregnancy. 85% of the cases, that is called as glucose intolerance with the first onset during pregnancy, whereas 15% only they have diabetes in pregnancy. That could be either type 1 or maybe type 2 antedating pregnancy that was first detected during the regular checkups, antenatal checkups. Now, hyperglycemia is one of the common medical conditions with pregnancy. Globally, if you see, the burden comes to almost 20.9 million live births and hyperglycemia in pregnancy, whereas 30%, that comes to 6.2 million, are in India. Hyperglycemia in pregnancy, so almost 6 million are due to the 30% of the burden is contributed by India onto the global incidence. And when the study was carried out, a small group of patients that was in study in Tamil Nadu, urban areas 17.8%, semi-urban 13.8%, whereas rural 9.9%. So it shows as the lifestyle changes are happening, the incidence has doubled as the socio-economic, the income of the family rises, and where the physical activity goes down. And we have seen that as they get used to newer gadgets and the physical activity is affected. So the incidence has almost doubled. Now, what the important thing here is GDM risk factors. Now, in a recent study from Tamil Nadu that globally recognized risk factors were not significant. Although risk factors to some extent to point women at risk, then testing, suppose you test women who are at risk, in that case, you'll be missing out almost 20 to 30% of the hypoglycemia in pregnancy cases. So in India, studies indicate that GDM may be associated with increasing socioeconomic, and similar trends have been found for diabetes also. So among women attending the rural health centers, doubling in income caused almost about 80% increase in the incidence of hyperglycemia in pregnancy. Just a very short pathophysiology to brush up the the undergrad. What we studied was something to do with insulin resistance due to placental secretion of anti-insulin hormone, pancreatic beta cell dysfunction that is caused by genetics, autoimmune disorders, chronic insulin resistance, gestational diabetes, and latent. And you have some of the dysfunctions, the beta cell dysfunction, these are contributing to GDM. Now, gestational diabetes is associated with number of maternal complications. Why is it so important to screen pregnant women for gestational diabetes? Because the complications most common are preeclampsia, polyhydramnios, prolonged labor, cesarean section, uterine atony, postpartum hemorrhage, and infection. These are the common complications we come across. Now, gestational diabetes is associated with number of consequences for fetus also. They are congenital anomalies, IUGR, increase in stillbirths, increased respiratory problems, jaundice, shoulder dystocia, neonatal hypoglycemia, infant respiratory distress syndrome. So these are some of the common fetal complications. Why screen for GDM? Consequences of diabetes on the fetus. During the first trimester, we need to screen to prevent malformations and fetal wastage. More incidents have been notified with the GDM. They give birth to, the fetuses have multiple malformations and fetal wastage. Second trimester, there is hypertrophic cardiomyopathy, polyhydramnias, fetal loss, and prematurity. Third trimester, more incidence of macrosomia, hypoglycemia, hypokalemia, and intrauterine fetal death again. Neonatal problems, birth injuries, metabolic disturbances, respiratory distress syndrome, polycythemia, and hyperbilirubinemia. Now, the vicious cycle of diabetes, that a young woman with diabetes, when pregnant, the pregnant woman with diabetes gives birth to a child of a diabetic mother. So here what we say is life cycle rather than lifestyle approach is important. So that we need to, women getting into diabetes or lifestyle disorders and then getting pregnant and giving birth to a girl who of a diabetic woman. So that is where we need to break with the life cycle approach. That's what it means. Now, whom to screen? National Diabetes Data Group advocates universal screening for GDM. Whereas selective screening, in that case, we miss out on almost 45% of the pregnant women are missed out. So 35 to 50% of GDMs would be missed out if we take as a selective screening. Screening women only who are at risk. Now, universal testing for GDM. All pregnant women in the community should be tested for diagnosis of GDM at all delivery points. So there are some of the guidelines. Just we would like to say is in 2016, USA, what they had the guidelines to focus on the nutrition practice during the treatment of women with GDM and referring them to the required daily nutritional assessment. Then you have multi-nutrition, medical nutrition therapy and activity, macronutrients, vitamin. This is about with the nutritional practice guidelines. Now, there are other guidelines by Canada, US, who had almost quite similar guidelines as to management. You have to screen them, and then management of the elevated glucose, then controlling the glycemic targets are there, nutritional therapy and weight gain targets, blood glucose monitoring therapy during pregnancy, and proper care during labor, delivery, lactation, and postpartum. That is how GDM women should be dealt with and counseled. So at the beginning, you need to screen them and divide them, whether they already diabetes in pregnancy or that's a gestational diabetes. Then have proper glycemic control. So most of the guidelines, they are following the same. But here, One, I would like to just highlight the global guideline in pregnancy and diabetes. That's the international guideline, which was in 2009. What it said was this guideline is for the pregnant women with known diabetes and gestational diabetes, glycemic control, testing for GDM, management, glucose levels, lifestyle management, insulin use during pregnancy, management after pregnancy, that is breastfeeding, and then to getting them into type 2 diabetes or screen them, if have a proper follow up as to prevent them to going into a postpartum GDM turning into diabetes. Now, these are some of the guidelines which have been given, but here's one in India. What are we following? The consensus evidence-based guidelines for management of gestational diabetes in India, that is 2014. The guideline presents an overview of the following consensus, that is the screening for GDM, blood glucose targets, monitoring, oral therapy, subcutaneous insulin, that is what has been the standard of treatment. Now, here we went to screen according to the guidelines. Now, early screening to pick up the undiagnosed pre-existing diabetes like HbA1c more than 6. Yes, these are the cases where this we need to pick up. These are the benefits of early screening. Now, the early screening in patients with high risk factors, repeat the test at 24 to 28 weeks and also around 32 to 34 weeks. World Health Organization in 1999 defined and classified criteria for the diagnosis of GDM. This includes GDM is a carbohydrate intolerance resulting in hyperglycemia of variable severity. That is the first recognition during the pregnancy. In the first and second trimester, fasting and postprandial concentration that is lower than the normal non-pregnant women. Here, there's one point to be highlighted. So elevated fasting and postprandial plasma glucose at this time in pregnancy may well reflect the presence of diabetes mellitus, which has antedated the pregnancy. Testing for GDM usually done between 24 to 28 weeks. There was a time when we were just doing GCT or GTT only around 22 to 24 to 28 weeks. But then in the meantime, we would be missing out a lot of cases, pregnant women who are not picked up in the early pregnancy or during the early pregnancy, they landing up into fetal wastage or IUDs. Now, to determine if GDM is present, a standard OGTT should be performed with 75 grams glucose, 250 to 300 ml, overnight fasting of 8 to 14 hours, plasma glucose, that is the fasting is checked, and after 2 hours. To meet the criteria of GDM, so what it was classified as a venous plasma glucose cutoff of more than 140 milligram percent at 2 hours, that is classified as GDM. It became popular, particularly in developing countries, as it was a simple procedure. So that was way back in 1999. That was the practice. So 2 hours glucose more than 140 milligram percent, that was taken as a cutoff. Now, diabetes in pregnancy study group India, a universal, so what it says, a universal screening which is simple, feasible, acceptable, and single step applicable in Indian scenario as Indian women have an 11-fold increased incidence of developing glucose intolerance during pregnancy. As we all know, our Indian diet is carb rich, which has carbohydrates with high glycemic index. So as we that is the staple diet which we are consuming on everyday basis. So there is, you see the incidence, 11-fold incidence of glucose intolerance during pregnancy. This is specific for Indians. when compared to Caucasian women and also among ethnic group. In countries, Indian women have the higher frequency of gestational diabetes. Now, Sheshaya et al. Recommended DIPSI as a single-step procedure irrespective of the mean. Now, pregnant women attending the antenatal OPD were given 75 grams of anhydrous glucose, 300 ml of water, and plasma glucose was estimated after 2 hours. Now, this 2 hours plasma glucose more than 140 milligram per 100 ml is taken as GDM. So, what are the benefits of that? This is a single step test, and it has for diabetes it was considered more than 140 or 120 milligram per 100 ml as decreased gestational glucose tolerance has been suggested. So two studies like 140 is considered as GDM, whereas more than 120 that comes as decreased gestational glucose tolerance. So now, what is the rationale for non-fasting status OGTT? So what it says, adequate and brisk insulin response in normal women maintains euglycemia. Now, despite glucose challenge, whereas in women with GDM, they have increase in glucose levels with glucose challenge due to impaired insulin secretion. So if a woman is euglycemic, definitely their levels are well maintained because of the timely insulin secretions. But in a woman with GDM, they will definitely have a impaired insulin secretion. So now the criteria says in pregnancy, 2 hours, more than 200 milligram deciliter, that is diabetes, and that is during pregnancy. And 2 hours more than 140 is GDM, and 2 hours more than 120 is categorized as decreased glucose, gestational glucose tolerance. So this is what the newer guideline, which is of interest for us, that is the DIPSI criteria. Now, advantages claimed are a single step for screening and diagnosis of GDM. The second visit is not necessary and least disturbance to the routine activity and economical. So what happens when we tell the woman to come with 8 hours of minimum of 8 hours fasting, she has to revisit, and that's how many may the compliance here we fail in the compliance. The patient may postpone it or may come back to us, we don't know. So in one visit, if we put the patient on this 75 grams of OGTT, that really works in a single visit. This can be picked up. This screening test works out better for our Indian women. Studies against doing DIPSI non-fasting. Now, what they say is, like the different groups, Pulkit et al. In their retrospective study of comparison of DIPSI and with the Indian Association of Diabetes Specialist diagnosis of GDM in 152 pregnant women observed that 74% were as GDM with DIPSI, and only 22% were diagnosed as GDM with alone, including 2 hours of plasma glucose as more than 153, so almost coming to 45%. They were diagnosed as GDM. So here what we need to understand is like almost 22%, we were just missing out on part of about 45% of the cases. They were like 2 hours plasma glucose more than 153. So they were GDM. Now the diagnosis of GDM by DIPSI leave 22% undiagnosed cases, which were detected by IAD PSG criteria, and concluded that IAD PSG criteria screening gestational diabetes is better than the DIPSI method. Now, what here they are saying is that you start with 50 initially, and then again around 28 weeks, you give 100 grams of OGTT. So now let us see what it says, the diagnostic criteria for GDM with the respective glucose levels. That is, according to WHO guidelines, fasting more than 126, whereas American guidelines more than 95. So that is what is important, more than 95, whereas according to our Indian, because you, as the Indian women are more at risk of GDM. So what it says is like the IAD, PSG criteria is fasting blood glucose more than 92. Yes, they are labeled as case of GDM. So that is the take home message here I would like to emphasize. The IAD PSG criteria, according to their guideline, the fasting uh, blood glucose, if it is more than 92, yes, you label the woman as GDM. Now, the national guidelines by Ministry of Health and Welfare India, pregnant women in the community testing for GDM at the first antenatal visit with 75 grams of glucose and 2 hours plasma glucose value. The 2-hour plasma glucose shows more than 140. Yes, you manage them as GDM as per the guidelines, whereas negative, that is less than 140 milligram deciliter, repeat the test at 28 weeks, and if she turns out to be positive, 2 hours plasma glucose is 140, then manage according to the GDM guidelines. If she turns out to be negative, then you manage as a normal antenatal care. Now, classification and diagnosis of diabetes. There are different screening methods and screening for and diagnosis of GDM. Now, the one-step strategy, the two-step strategy. This is according to the standards of medical care in diabetes 2021. The diabetes care, they have put a guideline as perform a 75 grams OGTT with plasma glucose measurement when patient is fasting, and at 1 hour and 2 hours. So if the 1 hour fasting is 92, the 1 hour plasma glucose is fasting is 92, 1 hour is 180, and 2 hours is 153 milligram deciliter. Now, these women, that is a one step we are supposed to do at 24 to 28 weeks. Now, the two-step strategy, perform a 50 gram glucose, that is a non-fasting with the plasma glucose. One is at 1 hour at 24 to 28 weeks of gestation in women not previously diagnosed with diabetes. If the plasma glucose level measured at 1 hour after the load is more than 130, 135 or 140, and proceed to 100 grams OGTT. Now, the second step, what it says, now you make it to 100 gram OGTT. That should be performed when the patient is fasting. The diagnosis of GDM is made when at least 2 of the following 4 plasma glucose levels, that is the fasting is 95, then you have 1 hour is 180, and 2 hours is 155 and 140. So this is according to the by the standards of medical care in diabetes, that is 2021. Now, management issues. What are the management issues? First, you have to educate the patient, medical nutrition therapy, pharmacological therapy, glycemic monitoring, self-monitoring blood glucose and the targets, fetal monitoring, ultrasound, planning of the delivery. So this is how you have to have a multi-pronged approach for the GDM patients. Now, the medical nutrition therapy goals: achieve normoglycemic standards, levels and prevent ketosis, provide adequate weight gain, contribute to fetal well-being, nutritional plan that includes your calorie allotment, calorie distribution over the day, how she has to spread out her calorie intake in her breakfast, lunch, and dinner, with including her snacks and the carbohydrate intake. Now, pregnant women with GDM, the foremost approach is the medical nutrition therapy and physical exercise. Now, 2-hour plasma glucose, postprandial blood glucose after 2 weeks. If she is being diagnosed with GDM, first educate her to get into the medical nutritional therapy and activity. Then after 2 weeks, again, you do the 2-hour plasma glucose. If it is less than 120 milligram deciliter, continue with the medical nutritional therapy and physical activity and keep monitoring as per the high-risk pregnancy protocol or recommended by the physician. That is, those are one group of the patient. Now, if the 2-hour blood glucose happens to be more than 120, then you take resort to the insulin therapy, and then you get into the pharmacological therapy. So monitor fasting blood glucose and 2-hour plasma blood sugars every third day, and more frequently for insulin, and biweekly for metformin dose and adjustment to maintain the normal blood glucose levels. As per the high risk, you need to follow with all the recommendation which according to the physician. Now, medical nutrition therapy, MNT, is carbohydrate controlled balanced meal plan. Now, what it says, nutritional assessment should be individualized. You can't just advise them to go on complex carbohydrate and all. You have to assess each and every individual according to their lifestyle. Some of the South India, there might be a different food intake. North, it might be a different. East, west. So you need to individualize according to the I can say the demographic eating habits and all that. Now, pre-pregnancy BMI optimal, weight gain, energy requirement during pregnancy to be defined. The first step, MNT, that's a general principle, about 10 to 12 kg weight gain. This all we need to educate to the patient, because she needs to understand what is expected out of her and her journey through this pregnancy, how it is going to be, and how her not having proper glycemic control could be detrimental to the fetus as well as for her, and she would land up into complication. This is what our approach has to be. So the general principle, 10 to 12 kg per, that would be the weight gain. 300 calories per 300 calories per day. Calorie counting, that is wise distribution of calories, no fasting, dietitian charts, diet plan according to the body weight. And obese women, they will require 25 to 30 kilocalories per kg, non-obese 30 to 35, whereas underweight, they may require a little more, 35 to 40 kilocalories. So dietary compliance is evaluated and reinforced during hospital visits. And every time you have to remind her that her diet has to be, carbs with low glycemic index. Now, what they are as we walk through, I will tell you about what are the low glycemic carbs. Now, dietary variety choices should be added. Now, pre-pregnancy, weight and BMI, optimal weight gain during pregnancy. So what do we have here to say is the normal, for a normal BMI, that is 18.5 to 24.9, the total weight gain is going to be 11.5 to 16 kgs. Whereas underweight, that is less than 18.5, the weight gain is going to be 12.5 to 18. You can expect that much of the weight gain. Whereas overweight, here, that is something 25 to 29.9 BMI, kg per square meter. The weight gain is a very marginal weight gain of 7 to 11.5 kg. Whereas in obese, here anything above equal or above 30, the weight gain is expected to be 5 to 9 kgs. So there has to be a real emphasis on the weight gain. Now, choices. What do we have? The choice of diet is carbs with low glycemic index, lean proteins, balance of poly and monounsaturated fats. But what we should be avoiding is eating for two, fast or feast, and these are the things to be avoided. Now, calorie dense diet, like you have with some of the refined carbs are there. So those versus the nutrient dense diet. So these you can just show them, give them a pictorial flyers and make them understand that these to be avoided and these to be added more, like the fruits, vegetables in salads or cooked vegetables. Uncooked or cooked vegetables are have to be added more often in their diet. Now, the glycemic index of the food, low glycemic, legumes, lentils, dried beans, peas, green gram, Bengal gram, rich in fiber, 30 to 40%. Now, medium glycemic index like fruits, they are almost about 45 to 55% glycemic index they have. High glycemic cereals like rice, white bread, root vegetables, potato, carrots, candy bars, and syrupy foods. So many of us who are working women, or they resort to some of the cereals. So those syrupy corn syrup, the sweet corn syrup is a content which has very high glycemic index. You know, the women may not have a lot of time to cook, and they resort to all the breakfast with cereals, and also we should discourage taking them, and ask them to add legumes, lentils, and dried beans. Now, diet with low glycemic are generally rich in fiber, and high fiber improves the glucose tolerance. Now, signal system, healthy versus unhealthy food choices. What are they? Now, the ones with the green on the green highlight, which is shown, these are all with the low glycemic. These are medium glycemic, and these are high glycemic. So steamed brown rice, white rice, biryani, these are the ones. Whole grain, white bread, cakes, cookies, croissants, then whole wheat roti, maida, paratha. All these are with the, so here we see is candied fruit, sweetened fruit juices are absolute no-no for these women. Now, understanding food properly, carbohydrates foods are essential for healthy diet of mother and baby. Large amounts of carbohydrates at one time should be avoided. Complex carbohydrates preferred over simple carbohydrates. Carbs should be spread over 3 meals and 2 to 3 snacks. So have 2 to 3 carbs at each major meals, or 1 to 2 at every snack. Now, the saturated fats like ghee should be less than 10% of the total calories. Obese and overweight women should take low fat diet. Moderate caloric restriction in GDM may improve the glycemic control. Hypocaloric diet may lead to ketonemia and ketonuria. Now, here we see proteins requirement increases to allow the fetal growth. Additional 23 grams to be added the protein per day. 2 to 3 servings should be consumed every day. Fiber, high fiber controls the blood sugar better. Now, the composition of dinner and lunch thali. Here we just see with this is the plate, and here it shows the vegetables. Now, this half portion of the thali should contain vegetables cooked as well as in form of salads. Now, here this 1/4 is contributed by the protein, and 1/4 of this thali containing that is part of the cereals. So one serving of the fruit is important. Now the dairy, one serving of dairy product is also to be added. So these are two, you can say 2 to 3. In snacks, we can add the fruit as well as the dairy. Now monitoring blood glucose, home monitoring, maintain a logbook, use a memory meter, calibrate the glucometer frequently. HbA1c, that is the ancillary test for feedback to the patient. Lower values when compared to non-pregnant women, lower blood glucose and increase in the red cell mass and slight decrease in the lifespan, measures every 2 to 4 weeks. Target what is expected is less than 5.1%. Now the glycemic targets, according to the American College of Obstetrician Gynecologists, the fasting, what they say, has to be maintained less than 95, 1 hour is 140 and 2 hours 120. Now the pre-meal is supposed to be less than 100, and HbA1c is should be maintained at less than 6%. Now, American Diabetic Association, what do they say? That pre-meal 80 to 110, 2 hour post-meal not more than 155. So these are all the plasma targets and not the glucometer targets. Now the pharmacological interventions, if the fasting, the glucose at diagnosis more than 120 can consider immediate therapy. Now the fasting plasma glucose more than, this is a red flag which we need to be very careful, that if the fasting plasma glucose, this is a take home message, I re-emphasize and reiterate on that. If the fasting plasma glucose more than 120, then you should not again send them for GTT and fasting plus glucose and waiting them. No, it has to be put them on immediate pharmacological intervention to be done for the better obstetric and the perinatal outcome. Otherwise, MNT, you can put them on 2 weeks if majority of fasting plasma glucose more than 95 or plasma postprandial more than 120, then start them on insulin. We'll just take you to the flow chart, which beautifully describes and how the treatment need to be followed according to the plasma glucose levels. Now, insulin, almost 15% of the GDM patients require insulin. Now, total dose that varies 0.7 to 2 units per kg. Fasting, blood glucose high, then 0.9 units per kg. Postprandial, blood glucose high, then 1.5 units per gram of the carb for breakfast and 1 unit for 10 gram of the carb around lunch and dinner. If both pre and postprandial blood glucose are high, and if women's postprandial glucose can be blunted, if you reduce the carbs too much, then she should not get into starvation ketosis. That is very important, and we need to take care. So the total of 0.7 units per kg to week, there has to be a gradual increase in the levels depending on her increase in the insulin depending on the blood sugar levels. Now, in a morbidly obese woman, the initial dose of insulin may need to be increased to overcome the combined insulin resistance of pregnancy as well as obesity. So it has to be addressed properly. Now, here we come across is pregnant women with GDM, the 2 hours more than 20, then yes, you put them on insulin. That is premix, insulin premix, 30:70, subcutaneous injections, 30 minutes before the breakfast, once a day, dose of insulin calculated by blood sugar levels. And yes, if the level is like, if you have labeled the patient as GDM, then put her on a medical nutrition therapy for 2 weeks, repeat her 2 hours blood glucose. If it is less than 120, continue with the MNT and monitor her blood glucose. Now, here again we have is if the blood glucose levels 120 to 160, 4 units, between 160 to 200, 6 units, and more than 200 is 8 units. That is how we get her into a euglycemic levels. Now, the fasting blood glucose has to be monitored every third day. Fasting glucose less than 95, 2 hours. There are again 3 group of patients. Fasting blood glucose 2 hours. Now, the fasting less than 95 and 2 hours less than 125, continue with your same dose of the insulin, MNT, and physical activity. So it has to be a multi-prong approach with pharmacological intervention and MNT and physical activity. If the fasting glucose is less than 95 and the postprandial is about more than 120, you need to increase the dose of insulin. If the fasting as well as fasting is more than 95 and PPBS is more than 120, you need to give insulin, increase it, and repeat it every third day. And then you get the levels to after third day monitoring, you get the levels and again follow it less than fasting less than 95 and less than 120, continue with the same insulin dose and MNT physical activity. Now here, if the fasting is 95, the postprandial is more than 120, then again we repeat the fasting with 2 units pre-breakfast increase and pre-dinner. Because here our main concern is you have to increase around the during the day, that after breakfast the dose, that is the pre-breakfast dose, has to be increased and add 2 units in the pre-dinner. So that's how you continue maintaining according to the levels of the blood glucose levels. Now, here we have oral hypoglycemic agents in pregnancy. What is their role? So let us see. There are 2 group of molecules which cross the blood placental barrier, and the other which do not cross, and the group which do not have a teratogenic effect. So here we have one group, tolbutamide, chlorpropamide, they cross placenta. So fetal hyper, that will give rise to fetal hyperinsulinemia, prolonged fetal hypoglycemia. Now, glibenclamide, that has a minimal transplacental transfer, and that has shown to give rise to sometimes hypoglycemia. But yes, definitely there's the second generation sulfonylureas and glyburide do not significantly cross the placental barrier. So fetal concentrations only 1% to 2%. Tolbutamide crosses placenta, followed by chloropropamide, and the least by glyburide, the least. Metformin crosses the placenta, but does not have any teratogenic effect that is shown in the rat models. Now, metformin comes under category B. No adverse effects can be given during the 2nd and 3rd trimester, versus the insulin, no serious adverse effects. So still no studies of metformin versus glibenclamide, but it is still safe to stick to insulin therapy. Now, the current treatment paradigm, what is it? Let us see. Metformin, the pros and cons, we just see like it attacks on the insulin resistance, and it has got a wider experience, but does not prevent GDM, cannot manage severe cases, not tolerated by all. See, many of the times whenever we have given the metformins for the PCO control, PCO management, we always tell them to take at bedtime, and then they get into nausea, vomiting. So this is the adverse effect by not well tolerated by all the metformins. It crosses placental barrier, so fetal risk we don't know. it is a category B by the US FDA. Now, in 2015, yes, insulin, it is the most efficacious because it matches with our body, which is secreted by the beta cells. Now, but it is injectable. Hypoglycemic episodes are very often, if the patient is not maintaining well with her carb intake, activity, she has to be well educated and well informed about the insulin therapy. And large for gestational babies are common. There is weight gain and unable to prevent fetal complications of GDM. Does not tackle the root cause. Now, let us see what in 2017 we came up with the inositols. Now, inositols prevents and manages GDM, attacks the root cause of GDM, leads to favorable fetal and maternal outcome, shown to be superior to metformin, safer than both insulin as well as metformin. Now, inositols, we just have a very, how it functions, what is its role. So members of inositols, they regulate the insulin signaling. Now, the myoinositol is required as for the carriers of the insulin. Now, these are present on the cell membrane. The myoinositol and D-chiroinositol are most important members of this inositol family. So here we see this, actually insulin is there. This insulin has to get into the cells. So these are the myoinositol is required for the insulin transporter that we need to understand. So the MI and DCI gatekeepers of insulin signaling and glucose metabolism. MI, which is necessary for the translocation of glucose transporters to the cell membranes, regulates the glucose cellular uptake. DCI, that stimulates the pyruvate dehydrogenase, and that stimulates insulin, beta cell, pancreatic beta cell, and it improves in the insulin secretion. This is required for the ATP production by regulating Krebs cycle. So all these effects take place when MI and DCI are present in physiological ratio of 40:1. Now, let us see what is the what happens if there is MI and DCI deficiency. So here we come across in normal pregnancy, the levels are normal, whereas in GDM, this MI and DCI deficiency is seen. So in GDM, MI levels are almost about 36% lower than the normal pregnancy, whereas this in turn, this MI in turn, that is changes to reduce DCI production. In turn, epimerase activity is lowered, and that in turn gives rise to insulin resistance. So DCI levels are further reduced by 50% in diabetic subjects. Now, MI and DCI in GDM management. So this normalizes this MI-DCI 40:1 in GDM that normalizes the insulin signaling and glucose metabolism, insulin resistance, that's how it diminishes, and the blood glucose normalizes. Insulin level, because the insulin resistance decreases, so the insulin levels come back to normal. Now, MI in GDM, the study 1, pregnant subjects with family history of type 2 diabetes, what it showed, according to the Diabetic Care in 2013, they did few of the studies. MI, when that was given for 2 gram twice daily, it prevents GDM. What are the benefits we saw? Almost 80% lesser GDM cases with MI compared to the control group. So this is how you see the control group, the GDM rates were high, whereas the group which was receiving MI, the incidence was very less. And that's how the macrosomia, it was much less in MI group as compared to the control group. Now, myoinositol and insulin resistance in GDM. What it says, the GDM patients, group A, who were receiving 4 grams after 8 weeks of therapy, what it was seen that they did a study and what were the benefits seen? So 2 gram twice daily meaningfully decreases the insulin resistance in GDM. Like this was the control group, this is the MI group. So what benefits we got to know was 240% decrease, better decrease in fasting glucose with MI, 68% of almost better decrease in fasting insulin, and 74% more reduction in insulin resistance, that is by the HOMA-IR, and adiponectin. Adiponectin plays a very important role in glucose metabolism as well as the lipid metabolism. So it showed that 449 higher surge in adiponectin levels. Now, inositol versus the insulin in GDM. So what it says, the GDM patients, the study group number was 60. Group A received 4 gram, whereas the group B received insulin. So what it said, it is MI 2 gram twice daily is as effective as insulin in managing GDM with no side effects. Now, in a study, what it showed that the levels, the insulin requirement in the insulin group, the 2 groups were there, MI group and insulin group. So when MI was given, the insulin requirement, it lowered the insulin usage during delivery. And the maternal gain, weight gain also reduced. Induced labor rate, that also reduced. So these are the benefits of myoinositol. Now, myoinositol and the D-chiroinositol, that is one group, and only MI alone is one group. Whereas MI regulates the cellular glucose uptake, DCI regulates utilization of this intracellular glucose into energy. So it is something, the insulin, MI is required for the insulin transporter. It works as an insulin transporter. So transfers the glucose through the cell membrane into the cell, through the cell membrane. So that is where the role of MI comes. Now DCI, it has an intracellular glucose. It regulates the utilization of that glucose into energy. Now, the synergistic effect of 40:1 DCI when added to MI at a ratio of 1:40 allows quicker normalization of glucose metabolism. Inositol is very safe in what the studies have shown. Inositol is very safe in pregnancy. Safety parameters similar to vitamin B complex group. It is water soluble and excreted via urine. Now, 4 gram per day in 2 divided doses has no side effects, whereas the dose of MI, 12 gram, patients complained of nausea, flatus, loose stools. 30 grams, they also had nausea, flatus, loose stools. So this was the pharmacological, that was published in World Journal of Pharmacy and Pharmaceutical Science, that this dose is did not have any side effects. Now, what inositols mean to GDM? MI therapy in GDM substantially lowers the complications of GDM. Now, the meta-analysis in 2015, what it showed is that inositols, they reduce macrosomia, shoulder dystocia, neonatal hypoglycemia, polyhydramnias, preterm deliveries, and last of all, the respiratory distress syndrome. So here it is shown that MI group, they had less number of neonatal complications. Now, what inositol means to GDM? This again shows that the study group that this prevents the trials reviewed in this meta-analysis conclusively reveal following points. The MI therapy prevents GDM if initiated right at the start of the pregnancy. So we need to follow with that 2-hour glucose and label the patient as GDM. So if it is started early in the pregnancy, definitely MI therapy is excellent. Effectively, and it is managed effectively, GDM all throughout the pregnancy. So MI corrects impaired OGTT in GDM. Now, what the discussion is the similar conclusion reached by Cochrane group. It appears that myo-inositol shows promise in reducing the risk of gestational diabetes. Fetal surveillance using ultrasound now. Next, after the pharmacological therapy, now how the fetal surveillance is very important between 11 to 14 weeks, early scan to confirm the gestational age using the crown rump length, measurement assessed for the major. See here the role of first trimester anomaly scan is very important, including acrania and anencephaly. All these need to be screened. 18 to 20 weeks detailed structural anatomy scan, which includes the spine, foreheart chamber, outflow tract, and 3 vessel views are very important to be picked up. 28 to 30 weeks, you do the serial growth scan is performed every 4 weeks to assess the fetal growth and amniotic fluid volume. The rate of fetal growth should be used to facilitate decision and treatment and timing of the mode of delivery. Now, labor and delivery. Pregnant women with GDM with good control of blood sugars levels may be delivered at their respective health facility, ideally institutional delivery. Pregnant women with GDM on insulin therapy with uncontrolled sugars, who are also on MNT and physical exercise and metformin or insulin therapy, should be referred at 34 to 36 weeks for proper tertiary care under a care of the gynecologist. Now, timing of delivery, GDM pregnancies are associated with delay in the lung maturity, so it is not proper to deliver them before 39 weeks. So routine delivery prior to 39 weeks is absolute no-no. So that is a take-home message. Once again, the lung maturity in fetus with GDM, that is delayed, that you should understand. So you should not correlate with the age. Here, the gestational age is very important. So do not deliver before 39 weeks. Now, such referred cases, they must get assured indoor admission or can be kept in birth waiting home with round-the-clock availability of medical staff for monitoring. If a pregnant woman with GDM with well-controlled blood sugar has not at all delivered spontaneously, so the role of induction of labor that should be scheduled at or after when to decide about it is important. In pregnant women with GDM with poor blood sugar control, yes. In these women to avoid, because they are more at risk of preeclampsia, they can be with previous history of stillbirths and infections, uterine atony, they should be delivered earlier. The timing of delivery should be individualized by obstetrician accordingly. Vaginal delivery should be a preferred choice, and cesarean section should be done for any obstetric indication only. In case of fetal macrosomia that is estimated above 4 kg, so you need to take her up for primary cesarean section at 39 weeks to avoid shoulder dystocia. Now, special precaution during labor. Pregnant women with GDM on medical management, they need to have blood sugar monitoring during labor by glucometer. The morning dose of insulin is to be withheld on the day of induction, and pregnant women should be started on 2-hourly monitoring of the blood sugar. IV infusion with normal saline to be started, and regular insulin therapy according to the blood sugars as mentioned in the table below. 90 to 120, you do not require any insulin, whereas 120 to 140, yes, you need to add 4 units, 500 ml of normal saline, 140 to 180, 6 units, and above 180, add 8 units. This is how you neutralize the sugars. So the rate of infusion is 16 drops per minute. Now, immediate neonatal care for baby of mother with GDM. All neonates should receive immediately essential newborn care, early breastfeeding to prevent any sort of hypoglycemia. If required, the sick neonate should be immediately resuscitated according to the government guidelines. Then the newborn should be monitored for hypoglycemia. Monitoring should be done at the time of delivery, continued every 4 hours till prior to next feeds. Now, the cutoff capillary blood glucose for hypoglycemia in normal birth weight less than 45 milligram percent and less than 54 in case of IUGR. So these are the things which we need to monitor in the neonates post delivery of GDM women. And neonates should also be evaluated for any neonatal complications like respiratory distress and convulsions, hyperbilirubinemia. These are to be monitored. So to conclude and to summarize, as we know, Indian women, they are almost 11 times, the incidence is 11 times more, and they are vulnerable for GDM because of their genetic or genetic makeup or the dietary intake. And that's how we pick up. So GDM screening, that is a universal testing, is mandatory. Then second, what are the levels you need to pick up? Put them on MNT activity. Yes, then you screen them whether they require any insulin therapy. Yes, now here comes the role. If they are picked up early, then GDM, they have to be initiated into MI and DCI combination therapy early in the pregnancy. And that's how their journey all throughout the GDM is well, they carry on with the pregnancy with good glycemic control and good obstetric outcome and perinatal outcome. And we need to educate women with the blood sugar monitoring. Self-monitoring of the blood sugar is very important. Educate the women about the nutritional therapy, pharmacological intervention, when to visit, and whenever we tell them for the insulin therapy, yes, once they are into insulin therapy, they should be made aware about the hypoglycemic events, what they have to take care. So considering all these, the journey of the GDM, you have to keep educating women about the different pharmacological therapy. And the MI as well as DCI is the role of MI as well as that takes at the root cause, that treats the root cause. It is working at the root cause. So in the early pregnancy, if this treatment is initiated, definitely they come out with a good glycemic control and a very good obstetric and perinatal outcome. Thank you for patient hearing. Hope you enjoyed the session. Thank you very much. I once again thank all my colleagues, my friends for patient hearing, and definitely Shield Connect, which is really creating so much of academic feast for all our colleagues in this field. Thank you.
Thank you very much, ma'am. So kind of you, and thanks for the wonderful presentation. It was always a honor and learning to hear you, ma'am. From the presentation, I've understood that uh, GDM not only influences the immediate maternal and also the neonatal outcomes. It is well established that the treatment of GDM reduces the risk of serious prenatal complications. Thank you, ma'am. So, if you allow me, then we'll take the questions from the delegates.
Yeah, we can take up the questions.
We have a first question, ma'am, from Dr. H.V. Sudhamani that what are the exercises you recommend for GDM patients in all three trimesters?
See, whenever we tell the exercises, so initially we should initially what we tell them is you take up the warm up as to start with the walk, then slowly we can tell them about the stretches, but all need to be done under supervision because here without any guidance maybe a walk of 20 minutes to 45 minutes that is a very good weight bearing activity. Second, yes, if she can take up with the stretches, squatting, and some of the exercises with taking with the dumbbells and all, that can be of help, but all need to be done under proper supervision. And yes, in some of the studies it has shown the underwater even walk, these are some of the exercises which are really beneficial.
Thank you, ma'am. Uh, we have one more question from Dr. H.V. Sudhamani. How do you treat polyhydramnios, which is very common in GDM patients?
See, polyhydramnias, here again, we need to, how do you label ultrasound depending on the AFI score? In this case, yes, if it is due to GDM, we proper good hyperglycemic, the glycemic control will definitely help us to, further progress polyhydramnias into giving birth to, giving rise to overdistension, and then they should not land up into preterm births, PROM, and all these complications. Yes, if it is giving too much of the respiratory distress, we can definitely, under ultrasound guidance, the tapping of the liquor can be done, which is very less nowadays. The incidence has come down quite a lot in the last 2 decades, I should say, last decade or so, where during our PG times we used to keep tapping, liquor for the polyhydramnias. But now, with so much of awareness, with so many investigation, good patient information, the patients are really picked up early and they have come out with good glycemic control, prevents further complications due to polyhydramnios.
Thank you very much, ma'am. Ma'am, I don't find any additional questions from the delegates. So, if
Okay.
you allow me, then we'll close this webinar.
Sure, we can. I once again thank Shield Connect for giving me this opportunity to speak on such a wonderful topic of gestational diabetes. Thanks all my colleagues for giving a patient hearing.
Thank you,
Namaskar.
ma'am. Thank you very much for your kind words. So, we look forward for your support in the future as well. And
Sure.
many thanks from the Shield team as well, ma'am. And I also thank all the delegates who are participating in this webinar. Be
Thank you.
safe and
Thank you very much.
thank you.